Well, I would second that. This is Dr. Thacker. I would certainly second it.
Okay.
I would. This is Dr. Isaac. I think we have a problem because there are pediatricians who are developmental pediatricians, and there may be pediatricians who specialized in developmentally disabled children who feel that they have a lot of experience with autism. Autism is a FDA-approved reason for prescribing these drugs, and it is the only drug that is approved for these behavior problems in autistic children. And I think that would be much too limiting to make that a standard recommendation. I think with time, as the prescribing group of pediatricians becomes more familiar with these drugs, I think that's going to be more and more something that pediatricians may very well feel comfortable with now that they have an FDA-approved indication for it. That's a fairly new occurrence. I think that I have other comments about this whole process, but I'll let someone else have the floor and come back and give some further comments later on.
This is Dan Castellanos. I've spoken that I'm only going to be available until 1 o'clock, but my understanding of the process is this was the initial meeting for us to kind of chart the course and look at all these issues, these very complex issues, and that it may be a little bit hasty coming up to solutions today rather than actually charting the course and getting to that question 3, if you will, and how to refine that process.
You're correct, sir. And I think rather than making specific motions, we want to get a general commitment of where the PA process goes from here. Does the process remain over the short, intermediate, or long term, specifically where everything is referred to the few child psychiatrists we have, with new and continuing therapies, because frankly that's potentially a lot of kids? Or do we want to get a commitment to move forward, as I said earlier, to create some criteria and some prior authorization processes where some of this can be handled by the clinical pharmacy staff here at ACA, reserving the more difficult cases for referral to the child psychiatrists?
This is Lisa Cosgrove again. I agree with Dr. Isaac in his evaluation of pediatric developmental pediatricians, that yes, they are very capable of handling that also. But I'm speaking from a generalist perspective that I think it's better that we have either the neurologist, child psychiatrist, or your developmental pediatrician diagnose these and confirm the diagnosis of these patients first before any prescription is given.
So do we want to allow at least the initial prescribing only from a limited scope of practice, I mean among child psychiatrists or neurologists, and automatically deny the other claims for referral?
This is John Lalekis. That would seem to make sense to me. I would think that especially the new cases should be referred, since here again we're talking about children under the age of 6, and in regards to those on a continuing basis be reviewed. I don't know what the medical team feels about 6 months or a year or whatever the standard course of therapy would be.
Well, if it's an autistic child,
it would be
lifetime.
Right.
So you're not going to get any difference there. But as far as continuing medicine, I don't think that that's a problem. New prescriptions, I think almost all pediatricians will go through the process of, getting the child evaluated to find out a basis for, an abnormality that comes up.
So this is Dr. Isaac again. I think if you're looking for a way to make the process simpler and not cumbersome on anyone, as long as you're routinely approving all of the continuation therapies. I don't see there's any point in burdening anybody with the approval process if it's going to be routinely approved. So I think if you eliminate that category, that would be a big drop in your burden.
So your recommendation is to leave the process where we only review new therapies and all continuing therapies are automatically approved?
Yes.
Okay.
I would agree with that. I think that's the intent. The other issue is, I think, one that Mr. Lalikas had brought up before was the type of physician. And you're not only looking at physicians that are requesting these medicines, you know, and this is a thought, I don't know who else would think of this, but if, for example, a pediatrician, or you're going to have areas where you have outliers and you have nurse practitioners taking care of patients, or even internal medicine taking, not internal medicine, but maybe family practitioners, and they're in outlying areas, they have no access to let's say, specialists there, but they have been able to get their child to go to see a specialist maybe in one of the tertiary hospitals, and they have a diagnosis from a specialist. If they've already had the workup done and they have the paperwork in hand that shows that they have been properly diagnosed, it seems to me if you had a copy of that workup, that would be an easy approval rather than trying to shift it over to one of your staff psychiatrists or staff developmental pediatricians or something like that. So that's just a suggestion. I don't know if it helps you or not.
Thank you.
This is Dan Castellanos before I sign off, but in general, I think in certain ways we're talking about just replicating the process, that the procedures that are already there, based on the assumption that certain kids need certain care. We don't want to interfere with the appropriate care, and we want to look at inappropriate care. And that the process, the utilization, the review process is based on certain criteria or parameters done in the first level review by staff, and that's where the trick comes in, developing those parameters, those criteria, which people have been mentioning. And then if they meet certain criteria, then go on to a level 2 review and take a better look at it, so therefore you put your bigger resources on a second or third level review instead of the front end review. All with the goal of making sure that the kids that need their care get their care, and that we hope to pick up the kids that are maybe inappropriately managed or treated.
Thank you.
Thanks. Bye.
Okay. Anybody else from the committee have any comments?
This is Dr. Isaac again. I have some general comments about the whole process. Number one, I see this as a cost containment measure by putting obstacles in the way of physicians prescribing. If these drugs were not expensive, we wouldn't be having this whole meeting. There are loads of drugs that are not approved by the FDA for children, which do not have to go through this type of process. I think this is a financially driven process, not a medical care driven process. And number two, I think we can all agree that the data on the proper use of these medications in young children is not there. So any recommendations that we make would not be based on any medical science or any facts. We'd all be flying by the seat of our pants.